for OBGYN specialists. As the OBGYN specialists, we work within the civil service. And of course, there are challenges that we face. We're giving out our clinical practice, but then we have public service regulations. Most of us know the medical guidelines inside out, but the civil service rules becomes another matter, because this governs the postings we have, our promotions, our leave, even discipline and allowances. And many times we can be shortchanged, or we can, get into trouble or get into issues because we do not know. So the goal of today's session is to bridge that gap. We want to equip every doctor here with practical knowledge of the rules that affect our career, our welfare, and our day-to-day work in government hospitals. When we understand these rules, we can advocate for ourselves better. We can avoid avoidable queries, and we can focus more energy on patient care. It's my pleasure to have Dr. Paul Okubor, who is a seasoned administrator, a permanent secretary in the Delta State government, Asaba. He has deep knowledge of both OBGYN practice and the civil service administration. And he'll be taking us through the key rules, common pitfalls, and then tell us how to navigate them. I want to implore all participants joining from different states and hospitals to pay good attention to everything. And I also want to thank them for making out time for this program, despite their very busy schedules. I encourage everyone to ask questions. We need to engage actively. The chat and Q&A session will be open. And let us know that no question is too basic. So if you think it, ask it. Once again, let me say, I wish all of us an insightful and interactive session. Thank you very much. I remain the webinar committee chair, Dr. Emily Nzeribe. Thank you and welcome.
Hello, good evening. Can you hear me?
Yes, we can hear you.
Okay. So good evening.
Sorry, PAMSEC. Chairman, webinar committee, we don't have his citation before he starts.
We have his citation, sir.
Please, let's go ahead with it first. Yeah.
Okay, sir. The person to take the citation is currently on transit, and he asked me to stand in for him. I will take the citation of our distinguished speaker, Dr. Paul Okubor. Dr. Paul Okubor is a seasoned medical professional, health administrator, and public sector reform advocate with over 2 decades of distinguished service in the healthcare sector. He qualified as a medical doctor in 1996 from the prestigious University of Benin. He became a consultant obstetrician gynecologist in 2006 and has consistently demonstrated excellence in clinical practice, leadership, and health systems management. He is an unrepentant advocate and promoter of maternal health. Dr. Okubor has held several strategic leadership positions within the health sector. He served 2 successful tenures as Zonal Medical Director of Central Hospital Warri from 2009 to 2011 and 2017 to 2020, where he played a pivotal role in strengthening hospital administration and advancing healthcare policies. In 2023, he attained the position of the permanent secretary, further underscoring his as a trusted technocrat and reform-driven administrator. He's a passionate advocate of good governance and positive healthcare sector reform. Dr. Okubor is widely respected for his commitment to accountability, service improvement, quality innovation, and sustainable healthcare development. His wealth of administration and public service leadership. I would like us to make welcome our distinguished speaker, technocrat, especially the permanent secretary in Delta. We are glad to have you.
Thank
Please
you
make
so
welcome our
much.
speaker with a virtual applause. Thank you, sir.
Thank you so much. Can you hear me? Can you
Yes,
hear
we
me?
Loud
can.
and clear, sir.
All right, good evening, distinguished chairman and ESCO elders, dear colleagues, and all participants. It is indeed an honor to serve as a speaker at this webinar organized by the esteemed ESCO and members of Sogon Eastern Sector. I honestly, sincerely commend the organizers for choosing a topic that is both timely and essential to our professional growth and career sustainability. As obstetricians and gynecologists, we devote significant attention to acquiring clinical knowledge and developing surgical skills. However, many of the challenges encountered during our careers do not arise from deficiencies in our clinical competence or work, but from limited understanding of the rules, regulations, and administrative processes that govern service. That is why this topic, understanding the Nigerian civil service rules, essential guidance for obstetricians and gynecologists, is most apt. For the purpose of this conversation and discussions that we're going to have today, we will try to use the outline as shown here from introduction to conclusion. We'll go through the overview of the Nigerian civil service, look at the public service rules and how they apply to the obstetrician and gynecologists with respect to the appointments, promotions, petitions, discipline, and then we'll conclude. Of course, the Nigerian civil service rules provides the framework for our rights, responsibilities, privileges, limitations, career progressions, discipline, and professional conduct within government service. A clear understanding of these rules is therefore not merely an administrative requirement. It is indeed a professional necessity that helps protect our careers, enhances workplace relationships, and enables us to serve our patients and institutions more effectively. Today, it is my prayer that we'll be able to explore the key provisions of the civil service rules as they directly affect us, examine common pitfalls that healthcare professionals encounter, and discuss practical strategies for navigating the public service environment while maintaining the highest standards of professionalism and ethical conduct. So like I said before, this conversation is most relevant because of the numerous challenges that we face as obstetricians and gynecologists in the course of our clinical work on a day-to-day basis. These challenges, like I said, are due mainly to a limited understanding of the rules, regulations guiding public service. The need, therefore, to have a firm grasp and understanding of the relevant rules and regulations cannot be overemphasized. As earlier insinuated in my introduction, which I'm again doing, clinical excellence alone is insufficient for career success in public service. It is therefore imperative that every obstetrician and gynecologist should acquaint themselves with these regulations. The reason why it is important that we do so is because all public hospitals operate under government regulations. The knowledge of the relevant rules protects our career progression and confers numerous benefits. It also improves administrative effectiveness and our leadership capacity. Clearly, it helps to avoid disciplinary pitfalls, as many of the disputes and problems arise from poor understanding of the rules. Good understanding of Nigerian civil service rule is part of the objectives of this discussion. We'll also look at identifying key public service rules as they affect us as obstetricians and gynecologists. And then, of course, like I said before, we'll see how we'll avoid problems and pitfalls that lead to disciplinary actions. Now, let us take a look at the civil service with respect to structure and personnel. The administrative machinery of governance is the civil service. It is indeed the permanent administrative structure of government that is responsible for both policy implementation and management of public institutions for effective service delivery. The civil service structure is the same and similar at both the federal and state levels. So you have the Civil Service Commission. At the central level, it's Federal Civil Service Commission, and the various states have their state civil service commissions. Of course, you have the various ministries, including Ministry of Health, where we belong. You have health service commissions, as the establishment wants to call. You have boards of hospitals, like boards of teaching hospitals and FMCs. At the state levels, you also have boards of teaching hospitals, and then you have hospitals management boards like we have in Delta State. And I am privileged to be the permanent secretary of the Delta State Hospital Management Board in Delta State. In terms of personnel, the heads of service sits at the apex of the personnel structure as the head, both at the federal level and then at the state. You have the permanent secretaries, you have directors, you have deputy directors, you have chief medical directors. And of course, depending on where you work, other nomenclatures in terms of personnel may be existent. The health sector is a major component of the civil service without doubt. A key component, a major ministry, in fact, belongs to health. Obstetricians and gynecologists are found at various sectors in the mainstream civil service. You'll find them as clinicians working in public hospitals and as administrators, even in public hospitals. And of course, you'll also find obstetrician gynecologists in the academia. They function as civil and public servants, administrators and clinicians in various capacities, as consultants working in the hospitals, as heads of departments, deans, provosts, as directors in the Ministry of Health, and of course, we have our chief medical directors leading our various public hospitals. It is important and imperative that very early in this conversation, we take a look at our rights and responsibilities as obstetricians and gynecologists working in the public service. And of course, our rights include the right to be appointed as consultant obstetrician gynecologist and the right to clear progression in our careers. We are entitled as a matter of right to remuneration and prescribed allowances. We are entitled to leave, the different types of leave, and I hope that we'll be able to look at some of them briefly. We are entitled to fair hearing. We have the right to work in a safe environment. And of course, continuing professional development is part and parcel of our rights as obstetrician gynecologists working in the public service. Our duties and our responsibilities to the public service will include our responsibility to patient care, competence, confidentiality, informed consent from patients whenever the need arises. Accurate documentation cannot be overemphasized. And of course, as consultants, the place of teaching and mentorship, I'm sure we all know that. Loyalty to the service is very key, as well as leadership and administration as part of our responsibilities to the public service. In terms of governance and regulations, let me state that the main governance and regulatory document of the civil service is the Public Service Rules. There are other regulatory documents that are available, and they include the Scheme of Service, the Financial Regulations, Public Procurement Act, Code of Conduct for Public Officers, hospitals, conditions of service as may be available in various hospitals, and as medical practitioners, the MDCN Code of Medical Ethics is very, very relevant for us. For today's conversation, we will be dealing mainly with the main regulatory document, which is the Public Service Rule. In the latest edition of the Public Service Rules, published in 2021, the foreword describes public service rules as an indispensable tool in the hands of public servants who want to succeed in their careers. In fact, the PSRO defines the relationship between employees in the public service and the government. It is again imperative that every obstetrician and gynecologist should be very conversant with the provisions of the public service rules to guarantee career longevity, because ignorance is not an excuse and may be very costly. The public service rule, which is applicable to all officers in the public service, regulates very key functions. Amongst them, you have appointments, promotions, petitions and appeals, discipline, leave, retirement, and of course, exit from public service. Let us take a look at appointments. And it is important at earliest time to state that appointments are made on the authority of the relevant appointing MDAs. Some appointments are made directly by the Civil Service Commission for the ministries, but the powers to appoint oftentimes are delegated to institutions with boards, to parastatals, that the edict setting of their boards gives them the powers to appoint. That is why I said that appointments are made on the authority of the relevant appointing MDAs as appropriate. Appointment into the public service can be unpensionable and permanent appointment. You have appointments that are non-pensionable. In these regards, we have contracts, we have consultants doing locum, and then we have some of our colleagues working as visiting consultants. Of course, in some instances, we also have people, obstetricians, gynecologists taking up appointments in acting capacities and special appointments as special advisors, as ministers, as commissioners, and the rest of them. The pensionable and permanent appointment is the most popular and sought after, and that is what we will concentrate on in our conversation today. What are the eligibility criteria for appointments? They include the fact that the vacancy has to exist. The government or the public institution has to declare that vacancies exist for recruitment of staff. The person to be appointed should not be less than 18 years, should possess the requisite qualifications as provided for in the schemes of service. And for consultant obstetrician gynecologists, the requisite qualification is clear. You have to be a fellow of the West African College of Surgeons or the National Postgraduate College of Surgeons or any other college recognized in Nigeria to work as a consultant. You have to be certified medically fit for public service by an authorized healthcare provider. In some instances, appropriate approvals must be obtained, and some of those instances include where the person seeking appointment was previously convicted for criminal offense, or where the person seeking appointment was previously dismissed from service or forced to retire or resign from service. For such persons to be appointed into the service, then appropriate clearance and approvals must be sought and obtained from the appropriate authorities. It's important that all necessary applicant information from the person seeking appointment should be obtained. Following appointment, there's a 2 years period of probation, and confirmation of appointment follows after that if the performance of the person is satisfactory and meets the establishment criteria for that MDA. Please note that failure to meet confirmation requirements after 3 consecutive attempts naturally means exit from the service. Again, failure to present for confirmation exercise after 3 years in service is also tantamount to exiting from the service. This is very important because we are often so busy as clinicians that we forget these basic things, that following your appointment after 2 years, you're supposed to present yourself for confirmation. And we see a lot of people who have worked 2 years, 3 years, 4 years, they've not done their confirmation. We see them. But because a lot of times these rules are not implemented as they should be, we often get away with them. But it's important that we know that confirmation is after 2 years. And if you are not confirmed after this number of years, you are making yourself open for the consequences. It's important to note that public officers seeking appointment are prohibited from membership of secret courts. And any person seeking appointment who is a member of a secret court should first and foremost denounce that court, that secret court, appropriately in court with appropriate declarations made to that effect. So let us look at promotions. Again, the powers to promote is vested in the appropriate authority as established. There are promotion criteria for anybody to be promoted, and the minimum criteria that you should meet or satisfy includes the minimum number of years that the person should stay in the position before being promoted to the next, that you've acquired expected skills and competence as provided in the schemes, that you've completed your annual performance evaluation report and currently performance management system as applicable. Of course, in the academia, publications and research are also part and parcel of what is used for promotions. The annual performance evaluation report is something we're all familiar with. It is an important mandatory annual assessment tool. It is used for assessing officers for promotions, including obstetricians, gynecologists. The common challenges that we often experience that may result in deferment of promotions or non-promotions are usually due to poor documentation. Again, the issue of delayed completion. We are working, we are busy, working in a public hospital, running from one private hospital to the other, that we forget that there is a need for us to be properly assessed. Again, the supervisors also have a role to play here, because if the supervisor doesn't complete the assessment using the APA forms, then of course, promotion will not happen as expected. It is important to note that at the federal level, the APA system for assessment and promotion is now being replaced with a performance management system. The performance management system is listed and very well profusely documented in the 2021 edition of the Public Service Rules, but it came into effect effectively in 2025, and it has replaced the APA, and all MDAs, at least at the federal level, are expected to comply with this provision. The PMS is a tool by which goals and objectives shall be set for employees, and individual performance is tracked, assessed, and reported upon. It is focused on measurable output of employees as well as specified competencies. In the performance management system, the capabilities of the supervisor is also discernible. So it's not just about the person who is presenting himself for promotion. It is also about the person, the superior officer, who is assessing the applicant who's presenting himself for promotion. Because from your reports, it will be clear whether you're doing well as a supervisor or you're not doing well. The key components of the PMS are listed here, from annual performance management timeline to performance rewards, and of course, under performance. Let us note that accounting officers in each MDA are responsible for implementation of the performance management system in their MDA. The PMS cycle runs from January to December. Let us note that. And the cycle commences after the management of the MDA has set out their goals and targets for the year. So what this means is that every ministry, department, and agency at the beginning of the year, the managers must sit down and set out the key goals and targets they want to achieve. And these goals and targets are escalated down to staff, to individuals. And then the performance assessment is based on periodic assessment of performance and appraisal processes within the calendar year. Like I said, key performance indicators are drawn and agreed upon by January of each year by the MDAs, with the final appraisal done by December of same year. Performance planning is also done at the beginning of the year. With respect to performance review, this is carried out throughout the year on a monthly basis, and it involves appraiser and appraisee discussions and interactions that are done very, very transparently. With respect to performance appraisals, these again are done on periodic basis. It evaluates the progress made with the achievement of the targets set at the beginning of the year. It involves both self-assessment as well as supervisor-led appraisals. Appraisal training should be made available to both the appraiser and the appraisee for effective appraisal system. Let us note, like I said, it should be an interactive and transparent process between the employee and his immediate supervisor. Rewards and results should be clearly linked to performance outcomes. So you look at the performance of the staff and then you reward appropriately those who did well. Employee performance should be used in determining rewards. Promotion decisions for deserving officers should rely basically on the demonstrated performance as reported by the appraisal reports. Let us look at underperformance for those who didn't do well. It is defined as an appraisal outcome which is below average and or not considered to be in line with the expectation for the respective job role. On a case-by-case basis. It's very important that each case of underperformance should be treated on its own merit. Prompt action should be taken in the cases of employees whose performance are a matter of concern. It is important to understand the root causes of the problems that led to the underperformance. And then, for these categories of persons, performance improvement plans should be adopted and put in place. Such employees who are undergoing performance improvement actions must be notified in writing, and this will again be done with utmost confidentiality. So it is not a matter that the entire workforce should be told that staff A has underperformed. Oh, staff A, this is or her assessment. Staff has to be informed officially and with all confidentiality. The implementation of the performance improvement plan should be coordinated by the appropriate director in the MDA along with the appraisers. At the end of the performance improvement plans put in place, affected employees should be given formal feedback on the status of their performance and necessary actions that will be taken subsequently. Comparing the PMS and the APA, significant difference exists in philosophy, methodology, and their application. While the APA system focuses mainly on annual assessments, PMS drives continuous performance improvement and accountability with reviews and appraisals done periodically, some done on a monthly basis, while APA is usually done at the end of the year. While APA asks, how did the officer perform over the past year? Performance management system will ask, what targets were agreed upon? How well were they achieved? And how can performance be improved continuously? Performance management system, therefore, represents a shift from the annual appraisal of APA to continuous performance management and results-based accountability. The performance management system, as you can all see, holds significant advantages. Some of these advantages are listed here. Promotes a result-oriented culture rather than merely assessing behavior and attendance, as is done in the APA system. It facilitates capacity building by identifying training and support needs. This is not existent in the APA system. It improves accountability as expectations are clearly stated. And it allows for regular interactions between supervisors and officers because both the reviews and appraisals are done with the supervisors interacting transparently with the officers that are due for promotion. Under the PMS, on a general level, public officers, including obstetrician gynecologists, are expected to develop annual work plans, document and keep evidence of what they have achieved, focus attention on outcomes rather than activities alone. So it's not just about running clinics, it's about what have you achieved? What are the outcomes of the clinic that you're running? Oh, you did 100 cesarean sections. What were the outcomes of the surgeries done? That is the important thing. It's not just the activity. You took 20 women with ruptured uterus to the theater, and 18 of them died. It's about the outcome, not the activity. You must take greater responsibility for personal performance and professional development, and be very conscious of the fact that performances will be rewarded while underperformances have consequences. Under the PMS, the measurable indicators for obstetricians, gynecologists in the public service may include. I'm taking my time to go through this PMS because it's a new thing, and I'm sure some people may not be aware of it, especially those working in the state's civil service, because eventually the states will have to adopt this. For obstetrician gynecologists in the public service, our measurable indicators may include number of clinics conducted, obstetrics and gynecological surgeries done, maternal mortality rates, timeliness of our response to obstetric emergencies, training and mentoring activities that we are involved in, quality improvement initiatives initiated by us, and of course, patient satisfaction and service delivery outcomes. These are possible key measurable indicators with which obstetrician gynecologists in the public service could be assessed under the performance management system. So let us look at appeals and petitions, one of the key functions regulated by the public service rule. An appeal, by definition, is a formal request by an aggrieved officer for reconsideration of the decision of an appropriate authority. A petition, on the other hand, is a formal complaint by an officer to an appropriate authority for consideration of a matter affecting the officer personally or bordering on general public interest. So an appeal is for a matter that has been done with decision taken, you're not happy about it, and you want to appeal for reconsideration. While the petition is for consideration of a matter that involves you or a matter of general public interest. Relevant guidelines that we must put into consideration in writing appeals include that appeals or petitions must be appropriately addressed. If the petition is to the permanent secretary, you must address it appropriately. If it is to the director, you must address it appropriately. Appeals and petitions should ideally be raised and concluded within 6 months of the event necessitating the appeal or petition. It is important to note that, as is often common Attempts shouldn't be made to bring political or outside influences to support our claims. If we are right, the appeal will speak for itself. Your petition will speak for itself. You don't have to bring in political, drop names, do this and do that just to support your claim. The appeals and petitions should follow proper communication channels as they exist in the MDA. The full names and all necessary details of the petitioner must be included. And you should conclude the appeal or petition by stating the nature of the redress that you're seeking. All these things are very important because if you don't do them, you stand the risk of your appeal or petition not being considered. Without prejudice to the constitutional rights of every citizen, of every individual to seek redress in the court of law. As public servants, you must ensure that you've exhausted all avenues provided in the public service rules as well as other relevant documents before proceeding to court. It is also imperative that you seek formal approval and get formal approval from the head of service before you proceed to court. If you fail, peradventure you fail to follow these processes of exhausting all avenues provided in the PSRO before going to court or getting approval from the head of service, the law says, the PSRO says that you will be suspended pending the determination of the case. So what that means is that if the rules were to be followed strictly, as documented in the public service rules, if you don't do these things, then of course you will be suspended. Even if the case takes 1 year, 2 years for a decision to be arrived at, you will remain suspended from service. Like I said, you need to follow these rules so that your appeals and petitions will be considered and not disqualified. Appeals and petitions will be disqualified if they do not comply with the relevant rules, some of which I have listed. If an appeal or petition deals with a case that is before a court of law, it will not be considered. If the writing is illegible or meaningless, of course, nobody will be able to know what you're talking about. If you use abusive, improper, or foul languages in writing your appeals or petitions, it stands the risk of being disqualified. If you're repeating a previous petition without introducing new and relevant matter, nobody will consider that petition. Like we said, appeal and petition should be presented after 6 months. An appeal or petition that is within 6 months, an appeal or petition that is being presented after 6 months stands the risk of being disqualified, not considered, except you present valid reasons for the delay. Let us talk about discipline. And I'm sure that it is a major thrust of our conversation today. If time permits, we'll be able to go through the whole gamut of what I've penned down here. If not, we'll take some of them and leave out some. But it's important to note that discipline is important and key to effective service delivery in the health sector. Without discipline, patient safety suffers, corruption becomes pervasive, and efficiency declines. The powers to exercise disciplinary control rest again with the appropriate authorities in the MDAs. It is the responsibility and duty of every public officer, including obstetrician gynecologists, to acquaint themselves to the provisions of the PSR, especially with respect to discipline. As I said before, ignorance is not an acceptable excuse. The public service rule broadly classifies matters of discipline into three categories. The first is general inefficiency, which is listed in Public Service Rule 10.0201, and it consists of a series of omissions or incompetence, the cumulative effect of which shows that the officer is not capable of discharging efficiently the duties of the office he holds. The second is misconduct, and about 15 of them are listed in the PSR and includes from scandalous conduct, refusal to proceed on transfer, habitual lateness to work, deliberate delay in treating official documents, negligence, dishonesty, refusal to carry out lawful instructions from a superior officer. They're all listed in the Public Service Rule. And with respect to misconduct, you will find them in PSR 10.0301. Serious misconduct is the third one. And serious misconduct is defined as specific acts of very serious wrongdoing and improper behavior, which is inimical to the image of the service and which can be investigated and, if proven, may lead to dismissal. Examples are listed in the PSR 10.0402, and there are over 22 of them, and includes falsification of records, suppression of records, withholding of files, engaging in partisan political activities, conviction on a criminal charge other than a minor traffic offense, unauthorized disclosure of official information, bribery, holding more than one full-time paid job. This is important. Holding more than one full-time paid job, nepotism or any other form of preferential treatment, divided loyalty, willful damage to public property, sexual harassment, membership of cults, obtaining employment into public service by fraud, obtaining employment to work as a consultant obstetrician gynecologist by fraud, aiding and abetting such employment fraud, enrollment into extant government payment platforms by fraud or misrepresentation, and of course, any obstetrician gynecologist that aids and abets such enrollment into extant government payment platform by fraud or misrepresentation can be charged for serious misconduct. We will look at some common violations that I believe often happen, and of course we can relate very clearly with. And these violations usually arise from conflicts between public duties, private practice, administrative responsibilities, and professional ethics. One of them is absenteeism and abandonment of duty. These actions disrupt patient care and service delivery and constitutes misconduct. Examples of these in daily practice will include failure to report to duty regularly, persistent lateness for clinics, ward rounds, theater sessions, or call duties. These are things that we see regularly, even amongst consultants, amongst obstetrician gynecologists. Leaving the hospital during official hours without permission is very common and very rampant. But all these things constitute misconduct for which, if you're not properly guided, will land you into serious problems. Unauthorized private practice. The public service rule clearly prohibits public officers from managing private businesses except where specifically permitted. This is very important. The public service rule prohibits public officers, including all public officers, from managing private businesses except where specifically permitted. This is key. In PSR 100425, exemption is granted to medical practitioners and lecturers in the university and other public servants who are interested in practicing in the field of ICT and agricultural business value chain, provided that it does not conflict with their official duties. Let me bring it down. PSR 100425 grants exemption to medical practitioners, provided that the private practice does not conflict with their official duties. Examples of unauthorized private practice will include running or managing private clinics without approval. We see a lot of people, oh, they become consultants, so they have a right to rent a flat and open a clinic and see antenatal gynae patients and do surgeries without appropriate approvals from the relevant authorities. You're supposed to register with the Ministry of Health. You're supposed to register with CSA. If you don't have these requisite approvals, then that private practice is unauthorized. Of course, this is very common amongst us. If truth be said, we see it all the time. Diverting patients from public hospitals to private facilities, redirecting patients who come to the clinic, who come to gynae clinics. Oh, this cannot be done in the government hospital. Oh, we don't have, the theater is not functional. This is not happening. This is not happening. Meet me by 5 p.m. so and so place. These are things that are happening and constitute unauthorized private practice, and they have negative effects on the system. So you go to so many teaching hospitals today, obstetrics and gynecology department, you don't see patients. And when you don't have patients, how do you train your residents? But the paucity of patients that we see in many of the teaching hospitals today as a result of the activities of practitioners in the system who divert and redirect patients from the hospitals to their private clinics. They make themselves unavailable in the government hospitals. And so the patients who come to the hospitals and don't meet the consultants over time will stop going to those hospitals and start seeking them where they know they will find them. Performing surgeries in private hospitals during official hours, using government time and resources for personal medical practice. Let us look at conflicts of interest. Again, here, this occurs when personal financial interests interfere with official duties and your responsibilities to the public service. Clearly, the Code of Conduct prohibits public officers from placing themselves in situations where their personal interest conflicts with official responsibilities. If you find yourself in this kind of situation, then of course know that it is conflict of interest and you're liable to be charged, and therefore you should avoid such situations. Examples of conflict of interest in our day-to-day practice includes deliberately creating delays in public hospitals to influence private patronage. I'm sure that we are conversant and we can relate very clearly with this because this happens on a daily basis in our hospitals. Redirecting patients to private laboratories, pharmacies, radiological outfits in order to receive commission. Ordinarily, you would think that this is something that is common amongst the junior doctors house officers, medical officers, and the rest of them. But the truth is that it is not alien to our cadre, to obstetrician gynecologists, to consultants who refer patients to do investigations that can be done in the hospitals. They send them outside to laboratories, to radiological centers, outfits, and pharmacies, because at the end of the day, there's a commission to be given to them for sending patients to those places. For administrators, for chief medical directors, and all those in a position to award contracts, awarding contracts to yourself, to your family, friends, and associates constitutes conflict of interest. Negligence of duty is serious misconduct, and in practice, especially obstetric practice, negligence may result in mortality for both mother and baby. So it is important that we take a look at it. And examples of negligence in our everyday practice as obstetricians, gynecologists will include failure to attend to emergencies. You're called out at night. Your resident registrar calls you out that there is a case of ruptured uterus, the case of primary postpartum hemorrhage that they think requires surgical intervention, and you fail to make yourself available. That will constitute negligence of duty. Failure to review critically ill patients. You are called out to review critically ill patients, and instead of coming, you delegate that responsibility to a junior doctor without proper supervision. If anything goes wrong, you're liable of negligence of duty. Of course, inadequate documentation of patient care, even when that care was properly given, will constitute negligence of duty. And ignoring established treatment protocols in the hospitals, if anything goes wrong, you will be liable for negligence. We'll take a look at financial impropriety. This is considered as serious misconduct, and if proven to be true, can lead to dismissal. Examples are listed here. Illegal collection of money from patients. We see that in our everyday practice. Doctors tell patients, oh, you're scheduled for myomectomy. My surgical fee is 50,000 naira, so you have to be paid before you go to theater. If they don't pay, you keep postponing, rescheduling the case for one reason or the other. The patient is supposed to come to theater on a Monday. By Sunday evening, for one reason or the other, you remove the name from the list. Some obstetrician gynecologists even go to the ridiculous extent of booking patients for surgery on days they know that they will be seeing their menses. So you look at the calendar and you schedule a woman for myomectomy on the 14th of July, knowing fully well that around 13th, 12th of July, the woman will start her regular normal menses. And then the excuse will be that you cannot operate because she's seeing her menses. I'm sure that we all know this is happening in our system. Receiving gratification before offering service, of course, said that. And then for administrators, manipulation of procurement processes, diversion of hospital consumables and drugs, falsification of claims, duty allowances, and other sundry payments also constitute financial impropriety. Let us look at falsification of records. This again is regarded as grave disciplinary offense with severe consequences. For obstetricians and gynecologists in service, it goes beyond forgery. It includes any deliberate alteration, fabrication, or concealment or misrepresentation of official documents. And the examples are listed. There are numerous things that we come across in everyday practice: altering the time of patient review after an adverse outcome, documenting examinations and procedures that were never performed, entering a cesarean section indication different from the actual indication to justify surgeries. I think we need to move faster for want of time. Altering theater records after maternal or neonatal mortality, manipulating theater registers, fabricating research data, claiming authorship or contributions that are not actually made. Insubordination is clear and refers to deliberate refusal to obey a legitimate and reasonable directive from constituted authority or a superior officer. In hospital settings, this can disrupt patient care, undermine discipline, and create conflict within the healthcare team. And this is absolutely unnecessary. Examples of acts of insubordination are listed here, and they can also be seen in the PSR: failure to comply with administrative postings and schedules, failure to participate in mandatory activities, and the rest of them. That will take us to abuse of leave and training privileges. And I'll define these as situations where specialist availability is crucial for effective service delivery, as you all know, and abusing these privileges that makes the specialist unavailable to render service significantly affects patient care, residency training, emergency coverage, and departmental efficiency. The examples of acts that will constitute abuse of leave and training privileges are listed here: proceeding on leave without approval. And then let us talk about repeated conference attendance to the detriment of service, which is very common amongst us. From January to December, we have 8 conferences lined up in different places, both within Nigeria and abroad. At the end of the day, we spend lesser number of days working in the hospital, making ourselves available, than we spend attending conferences. And all this will eventually lead to cancellation of scheduled cases and, of course, absenteeism from clinics. Political activities in service, this is clear, and it's important to note that PSRO expects every public officer to maintain political neutrality while in service. This is not prejudicial to your right as a citizen, your political rights to express yourself. The PSRO clearly states that public officers are restricted from engaging in partisan political activities. And examples are here: active partisan campaigning, political activities during official working hours. You are attending to antenatal women, and because of contemporary Nigerian issues, you begin to discuss with a pregnant woman, maybe based on what something that you said, and you delve into politics, telling the patient, the antenatal woman, why this party is better than the other party, why you should vote for this party or vote for this candidate and not vote for the other candidate. That absolutely is not acceptable. Sexual harassment and exploitative conduct, we'll take a look at that, and it constitutes serious misconduct and is one of the most serious forms of professional misconduct in obstetrics and gynecology. Obstetricians and gynecologists are particularly held to high standards. I'm sure you are aware of that, considering that the practice involves intimate examinations of women, sensitive discussions with women, and of course, the existence of significant imbalance between the doctors and their patients. Sexual harassment violates the PSR, hospital regulations, and of course, MDCN's Code of Medical Ethics. Examples are listed here: requesting sexual favors in exchange for treatment, surgery, medical reports is an example of inappropriate conduct or relationship with patients. Repeated unwelcome requests for dates or personal relationship reflects sexual harassment of colleagues and trainees. Victimizing trainees who reject your advances also constitutes sexual harassment. Abuse of administrative authority and power, that is also clear, and it occurs when one uses his official position, supervisory role, administrative office to victimize others or to achieve objectives outside the legitimate interest of the service. Administrative responsibility in ops and gynae is very clearly a responsibility entrusted for the benefit of the patient, trainees, staff, and the establishment. Using that authority, therefore, for personal advantage, retaliation, favoritism, or intimidation constitutes very clearly abuse of office and amounts to violation of the public service rules and ethics. Examples are listed here: victimization of staff, suppression of legitimate complaints and investigations, improper allocation of opportunities, as you can see listed, where you reserve conferences and workshops and sponsorships on a regular basis for those staff that are favored by you, or excluding qualified staff from training opportunities. Interference with procurement and resource allocations and the rest of them all constitutes abuse of administrative authority and power. Let us look at disruptive conduct and professional behavior. This again is clear. By definition, we could define it as actions, attitudes, and patterns of behavior that undermine teamwork, interfere with patient care, damage workplace relationships, and brings the system to disrepute. This is very uncalled for in obstetrics and gynecology practice, where collaboration and teamwork with other healthcare professionals is very crucial. Examples include verbal abuse and intimidation, bullying, unprofessional behavior during clinical care. Like we know, some people throw instruments out of anger while operating, throw instruments at junior doctors, throw instruments at peri-op nurses, and the rest of them. Hostility towards patients and relatives. And of course, disrespect for colleagues constitutes disruptive conduct and professional behavior. Breach of confidentiality is very important in obstetric and gynecology. And this occurs when an obstetrician gynecologist discloses a patient's personal or medical information to unauthorized persons without the patient's consent or lawful justification. Confidentiality breaches can have very serious professional, ethical, legal, and disciplinary consequences, especially in ops and gynae, and should be avoided by every obstetrician gynecologist. The list is endless. Examples are as documented here: discussing patients in public, disclosure to spouses without consent, electronic communication breaches, workplace gossips, breach of confidentiality in IVF and fertility practice. This is becoming very common, and you see obstetrician gynecologists publicly displaying babies born through IVF without proper parental consent. Of course, it will be said that consent was obtained from the parents, but again, we must look at the context of consent and the type of content obtained. Is it possible that the parents who gave consent for their babies to be publicly displayed did that out of the belief that they owe that to the doctor as gratitude for making it possible for them to have babies through IVF? If the parents gave consent, the babies didn't give consent. And of course, you know that internet never forgets. These babies could be labeled in years to come as IVF babies. So we need to take very particular care of this aspect that is becoming very rampant. And of course, all these public displays are essentially to sell the facilities where these babies were given birth to. Discussing fertility details with friends and colleagues not involved in care also amounts to breach of confidentiality. It's important to note that confidentiality is not absolute. Disclosure may be justified in some circumstances, and it's important that we know that. When the patient gives consent, when a court orders disclosure, then you must obey. When disclosure is required by law for sundry reasons, then you must abide by that. Public health regulations may require notification, and of course, you must abide by notifying the appropriate authorities. Information is needed for legitimate clinical care by the healthcare team. When that happens, then of course, such information will be given to the relevant persons. So that is for the common breaches. We'll look at the disciplinary procedure as captured in the public service rules. And it is done in such a way as to ensure fairness, due process, natural justice before any disciplinary sanction is imposed on any officer. The process for disciplinary procedure varies depending on whether it is general negligence, misconduct, or serious misconduct. But the essential steps are these: report of alleged misconduct. When something goes wrong, when something happens, it is reported. If the appropriate authority feels that there is a need to look into it, a query may be issued, and queries are condition precedent to disciplinary action. Query has to be written. The allegations must be disclosed. The rules allegedly violated must be disclosed in the query. Relevant facts and circumstances should also be disclosed. The period within which the officer must respond has also to be disclosed. It's important to note that following the issuance of queries, you are expected to respond to the query. And your response, when submitted, will be considered and reviewed, and necessary outcome decisions taken. If the explanations are accepted, the case will be pronounced closed. If the explanation is deemed unsatisfactory, then disciplinary proceedings may continue. There are circumstances where the explanation may be deemed unsatisfactory, but the appropriate authority considers that there is no need to continue disciplinary proceedings, and you will be given verbal advice or verbal warning. Investigation and disciplinary committee will be set up if the decision after considering your response is to continue disciplinary proceedings. It is important that the affected officer to be investigated is informed of the allegations and given a fair opportunity to respond. The panel will investigate the case, examine evidence, invite witnesses where necessary, and give the officer an opportunity to defend himself. The recommendations by the committee will be submitted to the appropriate authority, who will now take a decision. The authority reviews the report and decides whether the officer is exonerated. If the officer is not exonerated, decides whether a lesser punishment should be imposed or if a major sanction should be applied. Before we go into the outcomes, disciplinary measures, let us talk a little bit about queries. And to say that receiving query is not a disciplinary sanction in itself. it is actually an opportunity for you to present your case and exonerate yourself. The manner in which you respond is very important and clearly influences outcomes. You must be very careful when responding to queries. You must show proper courtesy. You must align yourself to the issues raised. You must read and understand the content of the query and respond accordingly. You must address in sequence all the issues raised in the query as they were raised. You must return your query within the stipulated time. And in concluding your query, you should conclude your query with respect to the authority that has given you the query. The disciplinary measures that can be applied include verbal warning, written warning, reprimand, surcharge, withholding increment, reduction in salary, reduction in rank, termination, retirement, and of course, dismissal. It is important to note that dismissal is the ultimate penalty for serious misconduct, and that an individual that is dismissed forfeits all claims to retirement benefits, leave or transport grants, subject to the provisions of the Pension Reform Act of 2014 as amended. So let us quickly look at leave and see that leave is authorized absence from duty for a specific period. There are about 17 types of leave listed in the PSRO 120201, from annual leave to proportionate leave. Annual leave is the most popular one. It's in accordance with your grade level. Leave can be granted at any time during the leave year. And note that any leave not taken within the calendar year concerned will be forfeited. So do not say that, oh, your work schedule is so much, and so because of that, you forgot to go on leave. That leave will not count in the next year. Appropriate approval should be obtained before spending leave abroad. Resumption of duty should be on the date following expiration of the leave. Failure to resume without acceptable excuse will be deemed as absent without leave, and you will forfeit pay. Exit from service could be through relinquishment, termination, resignation, retirement, and for retirement, important to state that the mandatory retirement age, at least for obstetrician and gynecologists in federal civil service, is now 65 years and 40 years of pensionable service, whichever one is earlier. In most states, is still 60 years and 35 years as appropriate. For professors, obstetrician gynecologists, the retirement age is as applicable in the universities. Directors and permanent secretaries' retirement could be based on mandatory retirement age or on the tenure policy. Important to note that all pensionable officers must contribute to the contributory pension scheme, and at their exit from service, they're expected to receive their pensions. And it's important that we know the requirements for pension payment so that we don't exit from the system 6 months, 1 year, 3 years after exiting from the system, we have not started earning our pensions. It can be very, very disturbing. when someone retires from service and fails because of his own carelessness, because he didn't do the needful, he didn't fill his forms, he doesn't start earning his pensions early. In concluding, therefore, it is important that I state that our healthcare system does not only rely on our competence, but on our strict adherence to established rules, ethical standards, and principles of accountability. We are, as obstetricians and gynecologists in public service, entrusted with the lives of mothers, babies, and families. And to discharge our responsibility effectively, we must combine clinical excellence with sound understanding of the PSR that governs our practice. A sound knowledge of the civil service rules enables us to navigate issues relating to appointments, promotions, leave training, discipline, performance management, and workplace relationships with confidence and professionalism. It also equips us to assume leadership positions effectively and contribute meaningfully to strengthening our healthcare institutions. Ultimately, the most effective gynecologist, the most effective obstetrician is not merely the skilled clinician. He is the ethical professional. He is the responsible public servant and a leader who understands that good governance and quality healthcare are inseparable. Thank you so much, elders, distinguished colleagues, ladies and gentlemen, for listening.
Wow, thank you so much. Please, let's give an round of applause to Dr. Paul Okubor. Thank you, thank you, thank you. I'm sure we have all been educated. Before we take the questions and answers, I would like our National President, Sogon, and also our Chairman, Sogon Eastern Sector, to make a few remarks. Then we'll take the questions and answers and talk about South East Sogon. Thank you. Thank you, sir.
Okay, thank you, Dr. Emily. I think I have to talk before the president. And what I want to say is to welcome him especially to this particular webinar. He's been here from the beginning. So we are privileged to have him in our midst. And we thank you, sir, for your presence. And also, let me use this opportunity to welcome some other big chiefs here. The former president of WACS, Professor Migbode, is here with us.
Seriously?
My teacher, Professor Ande, is here with us. Honorable Vice Chairman of the sector, Professor Eckert. We have the Sogon coordinator for Akwa Ibom State, Professor Ekanem, for Ebonyi, Dr. Bobby, where they're all here. I also have Professor Senarudna, Professor Kasu, Professor Eze, Professor Lebweye, Professor Dean, and Professor Yinda also here. These are the ones I could capture in the Zoom room. I'm sure there are many more on YouTube. Also, in a special way, let me also welcome Dr. Omome, who is the first lady to the presenter. I'm happy to see you here. So welcome, everybody. Over to you, Sogon President, for your comments.
Thank you very much, the chairman of Sogon Eastern Sector, and of course, thank you very much, the guest lecturer, my very good friend, Dr. Paul Okubor. It's been very exciting. This is extremely exciting presentation and goes into great depth into what we are supposed to be doing as professionals who are in service or even out of service, because a lot of things were really exposed that many people will benefit from. Well, I've always known Paul to be an excellent guy, So in that regard, I will say I am not at all surprised. So congratulations. And to the Eastern sector, the chairman, the secretary, and other organizers, kudos to you. And to my other senior colleagues who are here, President Wax, Emeritus, and others, please accept my felicitations. Thank you very much.
Thank you, Mr. President. We are privileged to have you. Before the questions and answer section also, let me also welcome and thank the guest presenter, Dr. Okubor. It was not by accident that we chose him, but this is somebody who have really walked through the civil service from from UBTH and so on and so forth. Unfortunately, the profile did not mention that he was trained at the prestigious UBTH. He only said UDBM, but let me add that one for him. So it's a product of UBTH, and of course, you know what those products can be. So we've not been disappointed. And like the president said, most of these things he said or he told us as things that we don't know. We act on ignorance. But remember, ignorance of the law is never an excuse. People just miss work, take it, travel without approvals and so on and so forth. When things are bad, we can be caught in the web. So let us not be caught. Let's cover our backs in whatever we do in our personal practice and in service delivery. So thank you, the chairman of this webinar, and we declare this floor open for question and answer.
Okay. Thank you very much, sir, Dr. Okubor, for taking us through this insightful, clear, and practical presentation. We will now move on to the question and answer session. Please, if you have question, please raise your virtual hand or type in the chat box. Presently, there is no question in the chat box. So please help us with your virtual hand or type in your question in the chat box. Thank you. Okay, Dr. Ebuogu, please go ahead with your question.
You can unmute yourself.
I'm not sure they're able to unmute if they are not co-hosts or hosts.
Can you unmute him then?
I've asked him to unmute, ma'am. Okay.
Okay, good evening to the presenter and good evening to all my teachers. Please, I have one question. I want to know, I'm asking whether there is the presenter, whether there is anything like voluntary retirement in civil service. Can you hear me?
Yes, I can hear you.
Hello, sir. I want to know whether there is anything like voluntary retirement in civil service.
Okay. I should answer now.
Okay, sir. Since there are no other questions, sir, please help us with the answer. Thank you.
Okay, so I want to use this opportunity to appreciate the presence of all esteemed elders whose names have been mentioned. I didn't have time to go through the attendance, the participants list, so I didn't know who and who, the people that were on the webinar. But it is, as always, exciting to see a lot of my elders, a lot of my teachers, a lot of my mentors on this webinar. And of course, to appreciate my dear wife, Omome, for having time to attend this webinar. Yes, part of the things that we listed as exit modes for the civil service included retirement. And so in daily practice, people can retire based on mandatory age as appropriate or based on number of years of service. People can also leave the service for reasons, for sundry reasons, for relocation, because they got a better job and all that. They can decide to leave the service. Now, whether you're leaving the service, especially when it's not compulsory, when it's not mandatory, will depend on how many years that you have been in the service. If you've done at least 10 years in service, then you qualify for retirement. If you haven't done up to the mandatory age of retirement, such requirement will be rightly called voluntary retirement from service. Is that clear? You haven't reached the mandatory age of retirement, which is 65 or 35 years of pensionable service as an obstetrician gynecologist. If you decide after working for 15 years that you want to relocate abroad or you want to go into private practice and you decide to retire, that retirement is not compulsory retirement. That retirement is voluntary because you decided to do it and can be aptly qualified as voluntary retirement. So yes, there's voluntary retirement.
Okay, thank you very much, sir, for that answer. We have another question in the chat box from Dr. Amina. It says, sir, please kindly clarify the private practice and public service rule, and also participating in NGO activities.
Okay, thank you very much. Well, I stated very clearly that the public service rule prohibits private practice. But I also stated that exemption is given to medical practitioners and lawyers working in the university, provided that such private practice does not conflict with your official duties. That is key. So as an obstetrician gynecologist, yes, you can have private practice, but no, you cannot allow your private practice to interfere with your official duties and responsibilities. So if resumption time is 8 o'clock and closing time is 4 p.m., you are expected to be at your official primary point of assignment by 8 and leave by 4 p.m., attending to the duties legitimately assigned to you. So despite the fact that you have exemption to engage in private practice, if you decide to, as we see often, to start your surgery in your private clinic by 8 o'clock and be in your private clinic till 10, till 11, then of course, that private practice is unauthorized. If you decide to leave the hospital by 12 noon to go to another private hospital to be operating, another private hospital where they're going to pay you extra money to operate, while your patients in the antenatal clinic are waiting, then of course that private practice is unauthorized. As an obstetrician gynecologist in the same line, you can of course engage in NGO work. But the key is that such work must not interfere with your official responsibilities. So you cannot say that under your NGO, you can leave the hospital by 10 to go and carry out free medical missions as part of your NGO work and leaving your patients and your responsibilities and duties in your primary place of appointment to suffer. But of course, you can use your private time for your NGO work. If you are not on call on a Saturday, if you are not on call on a Sunday, after working hours, you can, of course, do your NGO work. But to do your NGO work or your private practice work during official hours or the times that you should be working in the public service, then of course that is unauthorized and it is not expected of us as obstetrician gynecologists. I hope that answers your question, Dr. Amina.
Okay, thank you very much, sir, for that answer. Currently,
Hello?
there are other questions. Hello, sir. We heard
Yes.
you. Thank you very much. I said
Okay.
currently there are no further questions. I don't know. Please, if you have any more questions, kindly raise your virtual hands or use the chat box. Hi. Okay. So in the absence of any further questions, sir, thank you for your time. Thank you so much. I'll hand over to Dr. Emily for the closing. Thank you very much, sir.
Thank you, Dr. Odigoma Ikpeze, for taking the question and answer. May
Thank
we
you so
have
much.
Dr. Komomo tell our guests about the Eastern Sector Sorghum. Dr. Komomo, please. Komomo.
Good evening, everyone. You're welcome to Eastern Sorghum in a brief. Looking at the Eastern sector, and the Eastern sector consists of 9 states as shown on the map, other chapters outside the Eastern sector. And we are glad to have the National President, Professor Ikpeze, here with us today. You're welcome, sir. So Eastern sector is open for all and the webinar is open for all. Upcoming next week, Saturday, on the next week, Saturday, in the city of Uyo is going to be our second quarter Eastern sector annual general meeting. And it's going to be at Nelson Mandela Hall, Watt Bridge Hotel, opposite Ibom Hall, IBB Way, Uyo in Akwa Ibom State. The chairman and all the coordinators are waiting to receive the Eastern sector in the beautiful city of Uyo. We have our annual membership dues, 10,000 naira for members and associate members, 5,000 naira at least. You can do more if you can, and the account details are on our screen right now. Stay tuned. The webinar, we will have the next webinar for the third quarter of the year on the 4th of September on Friday, 7 p.m. And we are going to let you know the topic way beforehand so that you can register and be part of the webinar on the 4th of September. Follow us on our YouTube channel. This particular presentation and lecture was streamed live on YouTube, so you can go back and rewatch it and also share with your friends and colleagues so that they can be acquainted with the topic if they had missed it or they want to have a replay. Please kindly fill the webinar evaluation form currently. It's being shared there. And this webinar attracts 2 CME points. And this will add up to your MDCN qualification for your renewal of your next license. So please let us know how to serve you better. Let us know the topics you would like to have in subsequent webinars. Once again, thank you all the way from the Eastern Sector Webinar Subcommittee and the entire Eastern Sector. Thank you very much.
Thank you very much, Dr. Komomo.
Thank you so much, madam.
Yeah. May I call on Professor Cyril Dean to give a vote of thanks and closing remarks. Prof. Dean, please. Prof. Dean.
Thank you.
It appears Professor Dim is having network issues.
We can't hear him. Chairman, we can't hear him.
Chairman, can you conclude for us, please? Prof. Dim. Chairman, sir.
Okay. Professor Dim, it's like your network is a bit wobbly. So, well, I think all that remains is to thank everybody, especially our worthy guest speaker, Dr. Paul Okubor, the Permanent Secretary of Health, Delta State, and all our big chief that joined us, from the Sogon president to wax president, and to the first lady of the presenter, my teachers that were here, my other colleagues from all over the country. I saw consultants from the North, West, East, and South. We are happy to have you here. May I also thank in a special way my very, very active webinar subcommittee led by the Secretary of the Sector, Dr. Emily Nzaribe. Despite being an MD, she still has time for all this. And as well as the other members of the committee who have been very, very active and promoting the sector. Another thing, our website is very, very active. And in the next few days, it will activate it so you can pay your your yearly dues on website by clicking on a particular link. So I thank you, everybody. I didn't mention Professor Zome, that was there with us. Professor Ijome Zome, thank you for being with us. Thank you, everybody. Let's see you in Uyo. Both the associate members and members of the Eastern sector, we invite everybody from all over the country to our annual general meeting holding on next Friday and Saturday at Uyo. The Uyo Hospitality awaits us. Come and taste the fisherman soup. We'll be happy to receive you. Thank you again, and then join us for the next seminar or webinar on the 4th of September this year. Good night. Enjoy the rest of the day. Bye.
Thank you.
Good night, sir.
Thank you so
Thank
much,
you very
everyone.
much. Thank you, Dr. Paul.
Thank you, Ageless DVC.
DVC. Hey. Okay. Do I want to claim that one, though?
CMD, Dr. Zeribe, good evening, ma'am. Greetings from Umaya.
Mbamba.
Good evening. Good evening, ma'am. I'll soon be sitting at Okubor, ma'am.
Okay, I did.
Okay, ma'am. Thank you.
Thank
Bye.
you very much.